Welcome to the Informed Pregnancy and Parenting Podcast. I'm your host, Dr. Elliot Berlin. On the previous episode of our podcast, we had a listener as a guest. She wrote in because after reading an entire book on pregnancy and listening to many of our episodes, she had never heard of a complication called HELLP syndrome until she developed it 30 weeks into her pregnancy and had to act very quickly with little understanding of what was happening. During that interview, I promised to do a detailed expert-driven episode on HELLP syndrome. My guest today is an awesome Los Angeles-based OBGYN. She's just a warm, compassionate, and knowledgeable person who I was lucky enough to meet earlier this year. She has experience diagnosing and treating HELLP syndrome, and she's currently midway through her first pregnancy. Dr. Michelle Tsai, welcome to the podcast.
Hi, Dr. Berlin. Thanks so much for having me.
I'm honored. I really enjoy our working relationship, and I learn from you every time I see you, and I'm happy to share you with our audience today. Let's go back to the beginning a little bit into your background. When did you decide you wanted to get into medicine?
Yeah, so I decided I wanted to go into medicine, I would say kind of on the later side. Unlike a lot of my colleagues who kind of grew up knowing they wanted to go into medicine, I think I didn't really realize what I wanted to do until probably when I was an undergrad at UC Berkeley. And at that time, I had the pleasure of working with a lot of specialists at UCSF and doing some public health outreach projects. And at that time, that was kind of when I was introduced to women's health. And then I decided to apply to medical school. And even at that time, I was kind of torn in terms of what I wanted to do. I thought I wanted to do pediatrics, but after I delivered my first baby, I realized how incredibly special the experience really is. And the rest, I guess you can say, is history. And I decided to go into OBGYN.
When you started undergrad, were you thinking health at all, or
Not at all. And the funny thing is, unlike a lot of my colleagues, I don't have anybody in my family who's in medicine or healthcare. So not really having too much exposure on that, kind of thought I was going to go the business route, but it's funny how life works out.
Yeah. I mean, I kind of feel like the doctors kind of have to go the business route anyway. So you kind of get...
Yeah. Absolutely. That is so true. And I think, nowhere is that more true than kind of the climate of medicine today, where, a lot of it really has to do with, business in terms of, running your practice and coordinating with insurance companies. I mean, there's so much business aspect in medicine.
Yeah, and I feel like a lot of doctors are just givers. They go into healthcare because they like to take care of people, and business is kind of the opposite. It's about trying to figure out how to take care of your business and your income. So
Sure. Absolutely. And I think, there's something about the two that kind of intersects in terms of, taking care of yourself, but also, running a business and having kind of that self-satisfaction.
In medical school, how far in do you have to decide your specialty?
So luckily, you actually don't have to decide until you're kind of well into your third year of medical school, because the first 2 years are really more kind of didactic, classroom, textbooks. And then third year, you start doing what's called your clerkships, where you rotate throughout the hospital and you spend some time in every single specialty. And that's kind of how most people will decide what field they want to go into. And then the fourth year, the last year of medical school, is kind of dedicated to additional rotations in the fields that you're interested in, and then applying to residency, which is postgraduate training. And at that time, you do have to make a decision in terms of applying and getting recommendation letters and et cetera. But by then, most people kind of know what they want to do.
So when you did all the different shifts, were there any that stuck out to you as like, I'm definitely not doing that one?
Oh, absolutely. And the funny thing is, I went in thinking, pediatrics maybe. And when I did my general surgery rotation, I realized how much I loved, kind of the hands-on approach, the anatomy aspect of, just your daily job. And also there's something about surgery that it's like instant gratification, where there's something wrong, there's a problem, you go in, you fix it, you're happy, the patient's happy, we're done. So with that being said, I think for me, things are a little bit more, chronic in nature, things like neurology, internal medicine. I kind of knew that it was not for me, given that, I'm an impatient person. I see a problem, I want to fix it and, not spend the next 20 years talking about it. So I think OBGYN was a little bit of a surprise that I liked it, given I knew I liked women's health, but I didn't think that I would like the obstetrical aspect of it. And given that I really like general surgery, and then I ended up really liking the obstetrics part of OBGYN, I kind of knew that that was the right specialty for me.
Well, some people have a surprise pregnancy, and you had a surprise pregnancy career.
Oh, absolutely. And, the kind of running joke in medical school is, especially for something like OBGYN, the specialty chooses you, because there are few people that kind of go into medicine thinking, oh, I want the kind of lifestyle where you want to get up in the middle of the night to deliver babies. And, people try really hard not to like OBGYN, but, the specialty chooses you.
That's well said. A lot of people have told me that. So when you do your residency, by that point, it's all OBGYN training?
Yes. And kind of depending on the program that you're at. And I trained at University of Hawaii in Honolulu, which is, was a lovely place to train and live. And at that program, because we were the only program in the state of Hawaii, we were getting, all these cases from outer islands, even, as far out as American Samoa, Guam. And, just being at that program, you had the opportunity to see a lot of different pathology, and you had the opportunity to kind of, guide your own training in terms of your own interests. So some people know that they really like more the obstetrical aspect of OBGYN. So, they can do some electives on more high-risk pregnancies. And then other folks know that they really like the gynecologic aspect, and they can seek out more electives on surgical rotations, more experience in the operating room. So I feel like it was definitely a very well-rounded program.
What did you do after school's over? What do people traditionally do? Do you go work for another doctor or a hospital, start your own practice?
Yeah, that's a great question. And the funny thing is, now the kind of face of medicine is really, really transitioning where, the previous generation, most people came out of residency, going into private practice and solo practice and kind of opening up their own businesses. And I think, nowadays, especially with the lack of training in business that you get in medical school and residency, I think a lot of folks kind of come out and they opt to go work for a big company like Kaiser, or go into academia, work for a university, depending on your, kind of specific personal interest in, for example, research or business. I mean, the sky's the limit in terms of what you'd like to do after you're done.
Which route did you go?
The route that I went is a little bit of a rarity nowadays. I went straight into private practice. So after I finished in Hawaii, I actually moved to the San Francisco Bay Area, and I joined a private practice exclusively of OBGYN physicians. And the reason I say that it's a rarity is really nowadays, most graduates, they tend to shy away from private practice just because there's a lot of business aspect that we might not have a lot of experience in. And I think a lot of people, when kind of faced with the decision of deciding what job to take, going kind of the more secure, safe route where that there's experts who are doing business, who are kind of taking care of everything, that tends to be the preferred route. But I decided to go into private practice.
Because you also have a business mind?
My parents would love to say yes, but I think for me, it was kind of it felt like it was a good challenge to come out into, as a young graduate, as a young doctor practicing medicine. And I figured, if there's any time to face up to that challenge, it would be now. And it was a wonderful experience that I had for 4 years.
You say that there are no doctors in your family.
There are no doctors in my family.
But then you got married.
Yes, but then I got married, and of course, as you know, as luck and fate would have it, I married a wonderful pediatrician. And we actually met in Hawaii. And the funny thing is, we're actually both from San Gabriel Valley. So
Oh,
being
wow.
both from LA and meeting in Hawaii, it was kind of, it was a spark of fate, and we hit it off. And he unfortunately did not decide to go into OBGYN despite my persuasions, but he did end up going to pediatrics. So I ended up marrying a physician, and he's actually the reason I moved down to UCLA to join the academic practice here as a clinical professor, because my husband is a pediatrician with UCLA.
Well, it's our luck. We certainly gained tremendous benefit from it, from having you here. So do your deliveries become his patients?
Yes, and funny that you mentioned that, and it's so lovely because, the two of us really, we get to keep a lot of patients kind of within our family, if you will. So it's really been a wonderful experience taking care of patients throughout their pregnancy, and even prior to that, just in their general gynecological care, and then taking care of their pregnancies and delivering their babies, and, having my husband continue care of their child. It's really been, quite a pleasure and a privilege.
Maybe your child will go into geriatric care and keep the family business going.
Well, I think we would be very proud if that happens. But, whatever our child decides to do, we'll definitely, support her.
Well, it's a very fascinating background and path that you took to get where you are. Our episode today is about HELLP syndrome. And when we come back, we're going to talk not only about HELLP syndrome, but about preeclampsia. Don't go anywhere. We'll be right back with Dr. Michelle Tsai. Welcome back to the Informed Pregnancy Podcast. We're talking to Dr. Michelle Tsai. All right, so this episode, we promised to talk about HELLP syndrome. We had a listener write in, her name's Kelly Potter, and she had listened to the podcast. She had read books on pregnancy. She felt pretty confident and knowledgeable going into her pregnancy. And then partway through the pregnancy, she wasn't feeling quite right. Her doctor sent her to the hospital. She thought she'll just go in for some testing, and she even valet parked the car. Spoiler alert, it was something bigger than just a little bit of not feeling well. She was diagnosed with HELLP syndrome. So I said, you know what, let's do an episode with a knowledgeable, experienced OBGYN and talk a little bit more about what HELLP syndrome is, so that other people aren't taken by surprise should it happen to them, even though it's not super common. You've said in the past that you can't really talk about HELLP syndrome without talking about preeclampsia. What does that mean? Why is that so?
Yeah, absolutely. So, HELLP syndrome is much more rare than the preeclampsia. However, the two are very likely kind of variants of similar disease. Some people think of HELLP syndrome as a more severe form of preeclampsia. It may have the same origin, but, there are some very significant differences. For example, for preeclampsia, most pregnant women are, very well aware of this disease, and that it can entail basically having elevated blood pressures and protein leaking into the urine. And in terms of preeclampsia, the incidence, the percentage that we usually quote in terms of how many people get it, it's about 4 to 5% of pregnancies worldwide. HELLP syndrome is very different in that about 10 to 20% of patients actually don't have elevated blood pressures or protein in the urine. And it's also much more rare. Generally, we quote about 0.1 to 1% of pregnant women can develop HELLP syndrome. So, while they might be kind of on the same spectrum in terms of a similar disease, they really present very, very differently.
What does HELLP stand for?
Yeah, so HELLP syndrome, literally HELLP, it actually stands for the criteria for diagnosis. It stands for hemolysis, which means your red blood cells are kind of shredding. Elevated liver enzymes, which signifies liver dysfunction, and low platelets. And platelets are the cells in our blood that assist your blood to clot after an injury. So you can imagine, for folks that kind of present with these symptoms, the biggest kind of maternal complications that we think of is really kind of on the spectrum of bleeding.
So internal bleeding?
Yes. And, bleeding in terms of presentation, nosebleeds or bleeding from the gums after, brushing their teeth, usually that tends to be kind of a later presentation. However, in terms of HELLP syndrome, things progress very quickly. And generally, it's healthy patients who've not had any history of, high blood pressure, and suddenly they start feeling unwell, they get diagnosed with HELLP syndrome and, progressively worsen quickly. So things do turn, really at the drop of a hat. And in terms of, bleeding symptoms that we can see kind of in the later stage of the disease, I've seen patients come in, we have their IV put in and they're bleeding from the IV site.
Oh, wow.
They're having nosebleeds, their platelets are extremely low. And that's when, the situation can really quickly become an emergency. So it is considered an obstetric emergency.
You said that HELLP syndrome might be as little as 0.1 to 1%. Is preeclampsia significantly more common than that?
Yeah, so preeclampsia, really, it's much more common than that. And, in terms of preeclampsia, it's really much better defined in terms of, kind of the risk factors, things that we can do to prevent it. And HELLP syndrome, unfortunately, just given the severity and kind of how elusive the disease is, it's less well defined. But, in terms of the rate of preeclampsia, usually we quoted about 5%, but that's pregnancies worldwide. And, because it's much more common in women who are older when they become pregnant, women who are having their first pregnancies, really in terms of looking at the incidence, if you look at different populations, that number is actually going to change.
I know you mentioned for preeclampsia, elevated blood pressure and protein in the urine. Those are not things that you feel. Would somebody feel preeclampsia, signs of preeclampsia, or is it just you go for routine checkup? And
yeah, that's a great question. And, in terms of preeclampsia, people kind of present in both ways. So, a very common way is folks are feeling great. They come into the office for a routine prenatal check, and the nurse takes their blood pressure and notice that it's elevated. And therefore, they get sent to labor and delivery, the triage unit, get some labs done. They end up being diagnosed with preeclampsia. However, preeclampsia does tend to present with some classic signs and symptoms that we ask patients to look out for. And sometimes folks actually call in because they have been watching out for these symptoms and they're feeling unwell and they just want to run things by their doctor. And we're often very lucky that, they're cognizant of these symptoms and they're really watching out for them, because preeclampsia, can progress and become severe and potentially even become HELLP syndrome. And the things that patients, we usually ask them to look out for preeclampsia is if you're, having headaches that are unrelenting, with hydration, rest, even taking a little Tylenol, not really going away, or blurry vision, spots in the vision, anything going on with your vision that, it feels a little unusual. And then another sign we ask folks to look out for preeclampsia is if they're having abdominal pain. And usually that pain tends to present kind of more on the right side, right upper quadrant, as we call it. That's where the liver is. And it's because preeclampsia really affects all of your organs. And that includes your liver, which is why sometimes people have pain in that area, your kidneys, which explains the protein in the urine. And unfortunately, the placenta, which is actually an organ, an end organ in this instance, which of course affects the baby. So these are all things that we ask folks to look out for. And of course, swelling. Swelling is another thing that we generally have folks, really watch out for, particularly in their lower extremities. And of course, a lot of these symptoms can be nonspecific, and some people can normally have these symptoms during pregnancy. For example, in the third trimester, it's extremely common, especially right now we're, in the Los Angeles heat. With, a hot summer day, most pregnant women are swollen by the end of the day.
especially
So really,
the feet.
absolutely, the feet is kind of the thing that people complain about. But most people kind of are aware of what's normal for them. So, if you normally are swollen at the end of the day, you lay down, you put your feet up, and you notice, the swelling's really not going down. There's something that just seems odd. I always encourage my patients, really, nothing beats peace of mind. If anything seems out of the norm, it's best to touch base with your provider.
That's great advice. When you're in the office, what would be a clue to you that this, first of all, preeclampsia sounds like there's a prephase to something that's worse than preeclampsia. Is there something in between preeclampsia and HELLP syndrome?
Sure. And preeclampsia and HELLP syndrome, they're actually all on a disease spectrum. And kind of something that's more mild would be gestational hypertension, which would be high blood pressure with new onset in pregnancy, or chronic hypertension. These patients generally have high blood pressure outside of pregnancy. So all of these, diseases are kind of considered on, they're different diseases on the same spectrum. So especially for people that start developing elevated blood pressures, even without all the swelling and the protein in the urine, something that we watch very, very closely, because all these patients have the potential to have their high blood pressure develop into preeclampsia or HELLP syndrome.
Yeah, I guess preeclampsia, is it a pre-state to eclampsia?
Yeah, so eclampsia, it's kind of a little bit of an outdated term, because now, we say preeclampsia and preeclampsia with severe features, but eclampsia is basically severe preeclampsia, that presents with seizures. Oh. So it presents with neurological deficits. So this, of course, is extremely serious. And, nowadays, luckily, everybody, including the patients and the providers, watch out for preeclampsia very closely. So in terms of eclampsia, where the patient actually seizes from the disease, from the elevated blood pressure, generally, knock on wood, it happens a little bit more rarely.
Because you catch it before that.
Correct.
I remember a couple of years ago, somebody came into my office and she had a couple of the symptoms of preeclampsia, but she also just looked and felt like she had an awful flu. Like she was literally greenish in color, Caucasian patient. She was greenish in color, looked really fatigued, and just looked sick. And so I took her blood pressure and it was high, and I sent her right to her doctor.
Good catch.
But I've seen people who, even the same day, will go to their doctor. They're lively and bubbly and energetic, and they just happen to catch either the urine or the blood pressure. But she really looked sick. And I don't know how common that is, but it left an impression on me.
It's a great catch on your part. And, generalized malaise, just, generally not feeling well, feeling run down, muscle aches, you feel like, you're really exhausted. Of course, many people, especially towards the end of pregnancy, are tired, they're not sleeping well. So again, kind of a non-specific symptoms, but generally, I tell my patients, if you're not feeling well, something just feels not right, trust your gut, because your body, your health the best. If something feels like it's off, please seek care.
We're going to take another little break, and when we come back, we'll talk more about HELLP syndrome, and when it happens, what do you do about it? We'll be right back with Dr. Michelle Tsai. Welcome back to the Informed Pregnancy Podcast. We're talking about HELLP syndrome with Dr. Michelle Tsai. Okay, so now we talked a lot about preeclampsia and the spectrum of diseases, including all the way up to HELLP syndrome, and what some of the symptoms might be and when to call your doctor. So when somebody is diagnosed with HELLP syndrome, how significant is it in the moment, and what are the remedies? What do you do about it?
That's a great question. So in terms of diagnostic evaluation, really, HELLP syndrome, just given the name, the acronym, the hemolysis, elevated liver enzymes, low platelets, really the way we diagnose it is, we get some labs and we look for signs of all of these things happening. And of course, at the same time, we assess the mother, the baby, make sure everybody's stable. And this is actually why it's quite important if there's potential for HELLP syndrome or even severe preeclampsia. There's a need for care at a center with appropriate levels of maternal and neonatal intensive care, because many of these cases can be significant. So Sometimes I do see folks, who seek care at a community care hospital, and then they end up having to be transferred to another institution for a higher level of care. And really, many times people do well after the HELLP syndrome is managed, and the cure is delivery. So once delivery occurs, the placenta is delivered, the hormones are out of the system, the patients really tend to do quite well. But, there is a small chance, depending on the hospital that you present to, that you may have to be transferred for a higher level of care. And in terms of the general assessment, of course, we want to make sure, if there's elevated blood pressures, you may need medication, and that medication may be an intravenous, an IV medication, an oral medication, depending on, how high or how quickly your provider can get you that medication. And also another very important thing to think about in terms of the most significant neonatal, the complications of the baby is really in terms of preterm delivery, because many of HELLP syndrome cases are in preterm deliveries.
How early can it happen?
So kind of to, give you an idea for, how early this happens. 70% of patients with HELLP syndrome, they have it before delivery. And what that means is 30% of folks can actually have postpartum presentation with HELLP syndrome. Yes. And why this happens is very unclear, because as I mentioned, the delivery of the placenta really resolves the disease in most patients. But in the 70% of patients that have HELLP syndrome before delivery, 80% is before 37 weeks. So great majority of these folks are preterm. Right. Unlike preeclampsia. Preeclampsia, generally, it's less common before 34 weeks of gestation. And in terms of, the likelihood of preeclampsia, most people are diagnosed with it kind of closer towards your full term. So most people with HELLP syndrome do present that when they're preterm. And there's less than 3% of patients that actually have HELLP syndrome between 17 to 20 weeks. So you can imagine how devastating that can be when, you're that preterm. But in terms of, preterm delivery, of course, we worry about the baby. So potentially there are interventions that we do to kind of help baby do well, because again, the cure is delivery. So generally, we give a medication called magnesium sulfate. This is a medication given through the IV. It helps to prevent seizures, protect the baby's brain before 32 weeks of gestation. We usually give steroid shots for mom to help speed up the development of the baby's brain and the lungs. And then the steroids also prevents baby's brain in terms of bleeding and bleeding into the intestines. And of course, we always consult with the neonatal intensive care unit doctors, so that those doctors can come and talk to the patient and kind of give a general awareness of how early are we, what potential complications can we see in the baby? And of course, the $1 million question, how long is my baby going to stay in the NICU after we're delivered? And in terms of stabilization of the mom, at times they may need a blood transfusion, especially if their platelets are extremely low. As I mentioned before, sometimes we see patients, who are bleeding out of their IV sites. In that case, for delivery, we want to give them, a little bit of blood, platelets, just to bump up the count so that the bleeding, the clinical bleeding is lessened. And one very important thing to emphasize is it is possible for patients with HELLP syndrome to be delivered vaginally. And I think, really depends on how severe the presentation is. If we catch it early, the patient is relatively clinically stable, potentially we can absolutely induce your labor to have a vaginal delivery, because a vaginal delivery, of course, is preferred for both mom and baby. However, if mom or baby extremely unstable, at the end of the day, really our goal is to have a healthy baby, healthy mom. And in that case, a C-section may be indicated.
So the things that you were saying earlier, the magnesium sulfate, the steroids, those are before the baby's delivered.
Correct.
To help the baby both right before and also to prepare for an earlier delivery to get things ready.
Yes.
And what is the age? Because you mentioned that about 3% are really early, 17 to 20 weeks. What's the age of viability? At what point can we expect that a baby is going to live and recover and be healthy? How far along in the pregnancy?
So generally, and this is a little bit of a controversial question, because many times when you ask neonatal intensive care unit doctors, they'll say 24 weeks is kind of what we consider viability, meaning the baby at that point is capable of surviving outside the womb. However, a very important point to bring up is survival and quality of life are not the same. So, in terms of the magnesium sulfate to protect the baby's brain, the steroids to speed up development, all of those help baby survival and, function after, kiddos born and out of the womb and in an intensive care unit. However, there are babies that survive earlier than 24 weeks, especially, I would say in the last generation, really, we have started giving, these interventions, steroids, magnesium a little bit earlier than 24 weeks. For example, 23-weekers I have seen, do well. Of course, it's a very prolonged stay in the NICU. However, the survival statistics really depends on each individual child.
Well, it does not sound ideal, far from ideal, but it does sound like with some of the modern interventions that we have, mother and baby can do well, can be cared for and nursed to health.
Absolutely. Absolutely.
And much earlier than we used to be able to.
Absolutely. And the technology, especially, in the NICUs is remarkable in terms of, the survival rates. I mean, there's been such just the advancements that generally these patient in terms of, mom and baby, they really tend to do quite well. And really the most important thing is kind of recognizing the disease process, stabilizing both patients, the mom and baby, and then getting the baby delivered. Really, that's the most important thing because that's the only cure we have.
So 2 questions that come to mind. One is, I would want to know if I was pregnant, are there any things to do to try to avoid either preeclampsia and or HELLP syndrome?
Sure. And for prevention, so there's no evidence that there's really any sort of prevention that can prevent HELLP syndrome, unfortunately. But there are things we can do to reduce the risk of preeclampsia, interestingly. So some of our listeners may be on a baby aspirin. It's a low dose of an aspirin pill a day. And many reasons for giving this, but one of the biggest reasons is to help the placental blood flow, decrease the risk of preeclampsia. However, in terms of HELLP syndrome, really there's no evidence that there's any intervention that can prevent this.
If somebody has it once, are they more likely to have it again in a subsequent pregnancy?
Yes. And in terms of the recurrence, so, and this is a very important discussion that I have with patients that, have had HELLP syndrome or have had preeclampsia, because really there is a higher risk than baseline. And the number that we usually quote for HELLP syndrome in terms of recurrence, anywhere between 7 to 10%. However, for preeclampsia and otherwise gestational hypertension, just the high blood pressure in pregnancy, a little bit of a higher risk. So somewhere between 15 to 20%. Wow. So luckily, HELLP syndrome, it's a little less likely, but when it happens, it is very serious. Right. So, it's definitely a conversation that I have with patients, very early on after the pregnancy in which they're affected.
But considering that it's only 0.1 to 1% that you'll get it in the first place, 7 to 10% seems significant in terms of the recurrence.
Yes, absolutely.
Thank you so much for sharing all that information. I know this is going to be helpful, and hopefully anybody listening to this won't experience these conditions, but if you do, at least now you have a lot more information about it. Before we end, so you're pregnant with your first baby.
Yes.
It must be really weird to be on the other side of that table.
It's so strange because, really from the very beginning, and this is coming from somebody who, I see pregnant patients every day. I counsel folks on all types of pregnancy topics, from preconception to prenatal vitamins to things to look out for in pregnancy. And, experiencing everything on the other side has been quite eye-opening. And I truly believe that it's really helped me appreciate how much moms go through in terms of what it takes to get pregnant and to go through the pregnancy and, to retain any semblance of sanity. So I applaud all the listeners out there. And, in a sense, I'm confident that this is making me a better doctor in terms of the things that I counsel folks about. I'm really experiencing everything firsthand. So it's really been quite the learning experience.
It's kind of amazing. I mean, which other doctors really get to do that? You don't want to be a nephrologist and get all the kidney diseases, but as an OB,
Absolutely.
you get to kind of really go through it.
Yeah.
I try my best. One time I ate really bad takeout. It was leftover. I think it was spoiled. And I ate it at late too, at 10 p.m. I woke up 1 o'clock in the morning and I was having contractions every 3 minutes, about a minute apart. And I was like, I could maybe sort of relate a little bit to some of my clients.
Yes. Now for those of you who want their husbands to, partners to experience contractions, now you know what to do. Go get some bad takeout.
Yeah, I'll give you some. Yeah. So how's pregnancy going for you?
It started off a little bit rough. And the funny thing is, just as an OBGYN, I'd always predicted that the day that I become pregnant, I'm going to experience every awful symptom that I've ever counseled my patients about. And that prophecy unfortunately came true. So my first trimester was very rough. I had, terrible nausea. I was very fatigued and, just working, especially delivering babies in the hospital, it was a doozy. But, luckily, because of one of my symptoms, I actually got to meet Dr. Berlin, and it's because I started having really bad sciatica, back pain, hip pain, leg pain, starting very early on, around 8 to 10 weeks. So, I consider that a silver lining because he has really helped me to get through my symptoms. And now that I'm 24 weeks, I feel much better and I have much more confidence that I'm going to make it through the rest of this pregnancy. But it's been challenging.
Well, it's a huge silver lining for me because, as I mentioned at the beginning, we've seen each other's patients for a while, but getting to know you has been wonderful. And like I said, I learned something from you every time I see you. And now
Likewise.
I was able to share your wonderful knowledge with our audience here on Informed Pregnancy. So I'm wishing you the greatest of luck and joy in the rest of your pregnancy. No more of the bad symptoms, just all the great things that come with the golden trimester and the third trimester. And, with your delivery and your new chapter, I wish you only blessings and smiles.
Thank you so much. It's been such a pleasure. Thank you so much for having me.
My pleasure. And at home, thanks for listening to the Informed Pregnancy Podcast. If you have a topic you'd like us to address, just give us an email to info@informedpregnancy.com.
Doctor, give me the news. I got a whole lot of questions for you. This kid's gonna test my will. I got a lot to learn and my baby's due.